Well, good evening, everyone, and welcome to the Brian Crombie Radio Hour on Saga 960. As you know, if you've been listening to my show at all, health policy and advances in health is one of the topics that we come to quite a bit, and I'm quite interested in. And I'm joined tonight by Dr. James Shapiro. He is a transplant surgeon and regenerative medicine expert at the University of Alberta in Edmonton, Alberta, specializes in diabetes, liver transplants as well, and cancer. And we're going to talk to him about some of the efforts that he's got in diabetes primarily tonight. And also Mark Bosworth, who is the chair of a committee called Heading to 2022, which is interested in fundraising for diabetes. Gentlemen, how are you? Thank you for joining our show. Welcome.
Thank you, Brian. Thanks for having us on.
Yeah, thanks, Brian. Great to be here.
So maybe I could start with you, Dr. Shapiro. Tell me a little bit about what it is that you are specializing in regards to diabetes.
Okay, sure. So over the last 20 years, I've been involved with what's called the Edmonton Protocol, where we transplant cells that come from organ donors, and we transplant them into patients with difficult to control type 1 diabetes. We use the same organ donors that provide heart, lung, or livers for transplant, and here we're taking out the cells from the pancreas that make insulin, and we transplant those into the liver in a simple non-surgical treatment that we call the drive-through transplant. But with that treatment, patients have to take powerful anti-rejection drugs, and those have potential side effects. They can increase the risk of life-threatening infections. They can increase the risk of certain cancers, and they also have side effects in their own right on the kidney and other aspects. So they're far from a cure for diabetes. However, patients that have the cell transplant treatment with the Edmonton Protocol are able to often come off insulin for periods of time with outstanding blood sugar control. They don't have to monitor the blood sugars closely like they used to when they had diabetes in the first place. So what we're working on now mainly in the lab is to see if we can generate new cells, patients' own cells. So here we take a blood sample from a patient with type 1 or type 2 diabetes. We take the blood to the lab, and in the lab we unlock the mechanisms inside the cell. We can get into that in the science of it if you want, and how we do it. And we can essentially turn those cells back in time so that they were like the beginning cells in a tiny embryo. And then we can put them through a 27-day process, which is the process that happens in you and I before we're born. In the first 27 days of life inside an embryo, inside the pancreas, these cells develop that make insulin, the islets of Langerhans. So we can turn these blood cells, but very, very simply, turn the blood cells into human islet cells. And when we transplant those cells into mice, we can completely reverse diabetes. And they make human insulin, and we can follow them, and they seem to be safe and very effective in the mice. So our hope is that one day we can replace the need for the organ donors using patients' own cells. And by doing that, we can carry out a transplant with no anti-rejection drugs and no risk. And if we can achieve all of that, then I think that would be as close to a cure for diabetes that we could achieve.
Unbelievable. Fantastic. Well, we'll have to delve into this in far greater detail so we try to understand it. But Mark Bosworth, let's come over to you. You've got I understand, a background in leadership and consulting. Why are you associated with this program?
Well, I had the opportunity to work with Dr. Shapiro and his team in that work. And James and I began to discuss how I might be able to contribute, because my son Spencer is a type 1 diabetic. And I obviously have a passion for this and finding a cure, and a great respect for Dr. Shapiro. And he asked if I wouldn't mind supporting a small foundation that was partly under his watch called DRIFCAN, Diabetes Research Institute Foundation of Canada. And of course I said yes, and found myself in the chair role, and quickly began to say, let's discover new ways of raising money. I wasn't interested in kind of creating a bunch of events that cost money. It was really, let's direct as much as we can to Dr. Shapiro. Largely that led to this campaign. I had the good fortune of having a friend, Doug Ritson, who has no ties to diabetes, but we both landed on the fact that there's this 100th anniversary coming, and wouldn't it be great if we could tie into that and put a focused effort on supporting Dr. Shapiro's, world leading research, and direct 95 to 100% of the funds. And that's just what we've done. We have a small team of volunteers, Brian, and we're out trying to direct those resources and bring creative ways of bringing Dr. Shapiro that money. And the campaign heading to 2022, Help Eliminate All Diabetes, to recognize that 100th anniversary of the first successful injection of insulin. In many ways, Brian, we're calling it Canada's gift to the world, because it was 99 years ago, and it will be 100 years from now, a gift to the world as a cure of diabetes. So that's really our mission. Again, volunteer, grassroots, and we're being as creative and frankly, as we've worked at this, I think we've caught the imagination of a lot of Canadians. So it's starting to gain traction, and support like this is just making all the difference.
Excellent. Could either of you, just for a second, remind us of what happened 100 years ago? Who was it, and what happened?
Sure. So Frederick Banting, who was a medical student at the time at the University of Toronto, came up with this great idea of ligating the pancreatic duct in a dog and seeing if he could get insulin out of the pancreas. They tried before, they couldn't really get insulin out. He had this big idea. He tested it in the lab. He worked with Charles Best and another scientist from University of Alberta called James Collip, and his team leader was McLeod. And they together transplanted. Well, didn't transplant. They injected the extract of the pancreas into a child, a 14-year-old with diabetes, in January 2022, and that was the very first time that the blood sugar and the urine sugars fell with treatment with insulin, and that was the birth of insulin. And it's saved lives as insulin. It's a life-saving treatment, but it is not a cure for diabetes.
And Dr. Shapiro, I'm not the one to correct you, but let me try. You said January 2022. I think you meant January 1922.
I did mean 1922. I'm sorry. Yeah, I did.
That's a little while ago, 100 years.
Yeah,
we're going to take a break.
Yeah.
We're going to take a break for some messages. We're chatting tonight with Mark Bosworth and Dr. James Shapiro from the University of Alberta in Edmonton, and Mark Bosworth, who's chairman of a committee raising funds for diabetes research and diabetes research using cells that really could be a cure for diabetes. We're going to take a break and be back in just a minute. Stay with us. Well, welcome back, everyone, to the Brian Crombie Radio Hour, Saga 960. Fascinating conversation this evening on diabetes with Dr. James Shapiro of the University of Alberta in Edmonton, Alberta, who is a transplant specialist, a regenerative medicine specialist, and works quite a little bit in diabetes, also liver treatments, liver transplants, and cancer as well. And Mark Bosworth, who is a leadership consultant. If we have some time, it might be interesting to hear a little bit about some of that from you, sir. But because of his leadership consulting, he's got involved in a couple different committees to raise money for some of the work that the University of Alberta and Dr. James Shapiro are working on. We had an interesting interview, interesting overview from Dr. Shapiro about what's happening here. Let me ask you a couple of questions, if I could, sir.
Sure.
So what you said is that what you're trying to do is you're trying to take cells that used to be from other people, from donors, from the pancreas, and transplant them into people that have diabetes. Is that correct?
That's what we're doing now. We've been doing that for the last 20 years.
And how do you do that? So this is a live donor or a deceased donor?
No. So our current work is with brain dead organ donors, the same organ donors that provide other transplant organs. So there's clearly a shortage of organs to go around. But there's 463 million people in the world with diabetes, so there'll never be enough organ donors from that approach. It was really just a test to see if the cell transplant treatments could work, and they certainly do.
463 million people around the world with diabetes, and that's type 1 diabetes, not type 2?
No, it's all forms of diabetes, and our future work is really focused on all forms of diabetes.
Okay, and so right now, what is the focus on, type 1 or type 2 or both?
Both.
Both.
In the lab, we're working on both.
Okay, and so are you actually taking part of the pancreas and putting it inside a new a human person, or taking just a couple of the cells, or give me a sense of what the transplant's like? And is it Like, are you opening up or are you injecting, or how are you actually doing this?
Sure. Well, so the Edmonton protocol treatment is we take out a pancreas from an organ donor. In fact, they're taken from all over the country, flown to Edmonton. We process the pancreas. Takes about 7 or 8 hours to process and culture the cells, and then we infuse those without surgery into the patient's liver through the vein that runs up in the liver. It's called the portal vein.
What is infuse? What do you mean by
so
infuse?
These are islet cells. So the islet cells, you and I, we all have islet cells in our body. In people that don't have diabetes, they make insulin, but they also make other hormones. And when we purify them and put these balls of cells, we put around 500,000 of these balls that measure tiny balls. You see them under the microscope. You put them in the liver, they nest and they form a new blood supply and make human insulin.
And you say that they're flown to Edmonton. Edmonton is the only place that does this Edmonton protocol?
So Vancouver also has a small lab, and Toronto has processed some pancreases, I believe, in the recent past.
And is this only in Canada, or do people do this outside of Canada?
We've collaborated with around 40 different international institutions to help them set up.
Excellent. And who came up with the Edmonton protocol? Was this you, sir?
So I led the clinical team that tested that in patients 20 years ago.
And if this happens, if people get this transplant of someone else's cells from someone else's pancreas, are they? You say they're not cured. So what
No.
happens to them?
Well, they have to take powerful anti-rejection drugs, and I mentioned that those drugs have potentially dangerous side effects. So it's only really suitable for a very narrow spectrum of patients with type 1 diabetes. So what I don't want to do here is confuse you, and we're talking about two different things. One is the cell transplant treatment that's established in Edmonton. The other is what we're working on in the lab to make a limitless source of cells for all patients in the world with diabetes. That's the longer term goal.
Okay, so let's turn to that. So what you're now doing is research that is not in humans yet. It's just in the laboratory. And what you're doing is you're taking a person's own blood and you're getting some cells. And then what are you doing with them?
So we wind the cells back in time. There are a scientist who got the Nobel Prize for this work in Kyoto in Japan worked out that if he added 4 factors to an adult cell, he could wind it back and make it changeable. So he did this first with skin cells. He took some skin cells, he wound them back with his 4 factors, and then he turned them into beating heart cells. And he showed us pictures in the dish of these heart cells beating away. So what we've done is used similar kind of protocols that he's used and developed, along with work from other brilliant scientists in Canada and across the world, that have allowed us to take these cells, these newer cells, forward in time to make them into insulin-producing islet cells. It takes 27 days in the culture dish to do that.
Where are you taking these cells from?
They start from the blood of a patient.
So just blood cells. So you're just taking a sample of blood.
Syringe full of blood.
And it sounds like you found the fountain of youth. What are the 4 factors that take someone back in time in the development of their cells?
So they're called the Yamanaka factors. That's after the scientists who found them, and they're basically they unlock the mechanisms inside the cell that control it's called differentiation. What makes an eye cell an eye cell, an ear cell an ear cell, a hair cell a hair cell. So it can turn all these cells back in time to make them malleable.
So you're taking the blood cells and you're moving them through these 4 factors back in time, and then somehow you're moving them forward in time so they become islet cells.
That's right. You got it.
And how do you do this in this 28 days in a petri dish?
So so there's special kind of, they're called bioreactors, mini bioreactors, and the cells spin around in there, and we add different reagents and growth factors. Every day they get changed, the media gets changed, they get new growth factors, different factors every day that coax them along a new path. And then they basically, like a seed, they grow into a beautiful flower, and they stay like islets.
And so you've taken, let's say I've got diabetes, you've taken my blood, you've added 4 factors to it, you made it a cell comparable to what it would have been when I was first conceived. And then over 28 days of development in a petri dish, you move it forward to become an islet cell. It's still my blood. It's
your blood, your cells. So if we were to put that back into you, you wouldn't reject it. So
my body somehow recognizes it as my own blood and doesn't reject it like a typical transplant might be rejected.
You got it. That's it.
And where do you put it? Do you infuse it back into my liver?
Well, so the long-term hope is that, yeah, we'll put them back in the liver, just like I told you we were doing now with the organ donor cells. But we don't know whether that's the best place. When we first try these in patients, when we get to that, we'll be putting them probably under the skin inside a containment device, so we can just pop them in, leave them for a period of time, see how they grow, make sure they're safe, then take them out. But the first steps there wouldn't be trying to cure a patient. They would just be testing the cells to see if they were safe. And then when we've passed that stage and recognized that we've got cells that are usable, then potentially we could put them, say, in the liver in a patient with any form of diabetes. And since the patient's own cells are back, they should function fine. The only catch is patients that have type 1 diabetes, the autoimmune diabetes, where the immune system has damaged the pancreas cells in the first place. There, the immune system could potentially attack these new cells. So we're going to need some additional strategies to help with that.
And what stage? You said that you're testing this on mice right now.
Yeah.
So is that the stage that you're at in the development?
Yeah. So these are human cells from human patients with different forms of diabetes, made the cells, put them into mice, reverse the diabetes in mice. That's where we're at.
Okay. Out of interest, how do you cause diabetes in the mice?
So there's there's some mice get diabetes spontaneously. Other mice, you give an injection of a drug called streptozotocin. It's a toxin that destroys the cells in the pancreas.
Okay. And what's happening to these mice that have artificially been given diabetes? Do they cure themselves?
When they have the transplant, it takes about a month for the cells to engraft and get a new blood supply, and then they make human insulin, and basically the diabetes is resolved. It goes away.
And how long have you studied these mice over a long period of time? Is this cure permanent?
So we're always cautious with the word cure, but we have tested mice for long periods of time. We've used different kinds of these stem cells. They are stem cells. That's what we're talking about. We've worked with a company in San Diego called ViaCyte, and they make an embryonic stem cell. Those are not patients' own cells, and those ones we've tested out to around 5 years and made sure that they are safe in mice. And we've also carried out first in human tests in patients with those.
Well, this sounds like almost as earth-shattering as what happened 100 years ago. So good luck. What's the stage to go to next? Is this like a drug where you have to go through phase 1, phase 2, phase 3 trials? What are the stages that one needs to go through from an exploration and proof standpoint before you can get approval?
Well, the next stage is I'm looking at Mark here, because we need that. We need the help of heading to 2022, because we need funds. We need $22 million to take where we are right now to the point of carrying out some reasonable size scale first in human trials, and that we're hoping to do in the next months to years.
Now, a typical phase 1 for a pharmaceutical drug trial would be in healthy humans. Is that what you would do, first of all?
Well, that's an interesting question. I think it depends how we do the studies. So if we put the cells inside a device that allows us to pop them in and remove them at different time points, it could be done in normal volunteers. But in this case, probably we would do it in the patient's own body with who has type 1 or type 2 diabetes.
So, versus the typical phase 1 where you're just studying for safety, you would be studying for safety and efficacy right away.
It wouldn't be efficacy to start with. We'd be putting a tiny sample of cells in. We wouldn't be looking for efficacy when we first started the trials. But as we build it up, and these things are all done in iterations. So if we find the first series of trials are safe, then we increase the dose and we see what happens.
Okay, so you get the $22 million and you do the phase 1 clinical trial. You put some of someone's own blood back in them in a little device under the skin, and you release it a small amount over time. How long does this take? How many people do you have to have? When do you know if you've been successple with the phase 1?
Those are complex questions. If I look at how we began 20 years ago with the cell transplant treatment, we transplanted 7 patients at that time, and all 7 patients came off insulin 20 years ago in Edmonton. And so then we expanded it, and we've treated there's 2,000 people around the world now that have had that Edmonton protocol type treatment, maybe more. So I think we would start the same kind of way. We'd start with a small group of patients. It's not really like testing a drug where you have to test it in thousands of patients. This is a patient's own. I think the big issue here was going to be how the regulatory authorities handle this. We have to work with Health Canada. We have to work with the review boards, the ethics boards, and make sure that we do everything carefully, slowly, in a stepwise fashion.
Okay, so assume you do all this, when would you go into either phase 2 or phase 3?
So I think those are complex questions. I don't know if I have the exact answers, but on timelines, I can tell you what we're trying to do here is map out the process. Right now, we have technicians and research associates working day and night, adding these growth factors to the bioreactors, and they have to do a lot of work to find enough cells to treat a mouse. And now we're trying to scale up that process. We're working with experts in artificial intelligence, in machine learning, and in robotics. And we're working with a company called Lonza that has a device they call the cocoon. It's a sort of size and shape of a bread maker. And inside that device, it can basically rock and add all these ingredients at the right times and take over some of the tasks that the technicians and the research associates would have to do. And the ultimate vision there is that you'd have a room full of these cocoons, these devices, and they call it the orchard, where you would grow patients' own cells, personalized medicine at its best.
But are we talking about phase 1 and phase 2 or phase 3 in a year or 5 years?
Well, I would hope that in a matter of months we'll be carrying out the initial phase 1 trials, but they would be safety trials, just safety.
Right.
And as we move forward, we'd then be looking at phase 1, 2, looking at safety and preliminary efficacy. And as we move forward with that, we'd then be involving other centers and transplanting larger numbers of patients to a point where we could potentially do a phase 3 trial and maybe a randomized control trial against standard or best current day insulin and monitoring systems. So we could see which is better, the cell transplant treatment or the current insulin and monitoring systems.
And I apologize to keep asking, but so this whole process, do you think it's a couple of years, 5 years, 10 years?
Well, I can see as far as my feet, and I can look across to the horizon, so I can easily see what are the immediate challenges ahead of us. That's fine, but promising patients a cure within 5 years is a dangerous path to go. There's too many people claiming that over time, and I'd be the last one to want to give you an exact timeline. How long will it take to get this ready and available for 463 million people? That's a big task ahead of us. It's going to involve industry. It's going to involve a lot of science, and there's a lot of unknowns.
This right now is a research project at the University of Alberta, but it sounds like you've got a couple of private companies involved. Is this something that you're looking just for donations for, or are you actually looking for investment?
Well, at the present time, it's purely science. So, and it's applied science. Everything we do is bench to bedside. So we're trying to treat patients. And I think as we move forward, potentially, this could be taken over by companies and others. But at this point, we're focused on donations and trying to move the science forward in an accelerated fashion.
Fascinating discussion tonight about a potential cure for diabetes. Dr. Shapiro will hate it that I use that word cure, but could be a potential cure for diabetes by taking people's own blood, adding 4 factors to it such that blood cell ends up becoming like a cell at the beginning of life, and then over 28 days maturing it in a petri dish or in some unit that Dr. Shapiro's called a cocoon that would end up allowing it to become an islet cell that you would then infuse into a person's body and take care of creating insulin and solving their diabetes. Unbelievable. Just fascinating. Dr. Shapiro, thank you so much for that explanation. We're going to take a break and come back more with Mark Bozzo and Dr. Shapiro in just a minute. Stay with us. Wow. Welcome back to the Brian Crombie Radio Hour, Saga 960. Fascinating conversation tonight with Dr. James Shapiro and Mark Bosworth. Mr. Shapiro, Dr. Shapiro is a transplant specialist, a regenerative medicine specialist, looking in depthly at diabetes and a potential solution to 423 million people around the world today that suffer from both type 1 and type 2 diabetes. I never realized it was so big. And really quite an innovative new method using people's own cells to regenerate to create insulin in their body. Sounds, Mr. Bosworth, Mark Bosworth, like this is going to take a lot of money. And it's going to take a big effort to raise funds to sponsor this phase 1 clinical trial that Dr. Shapiro wants to do. Tell me what you're doing and how you're doing it and how much you want to raise and how you're going to do that.
Well, I mean, we're playing off the number 22, and Dr. Shapiro has said, 22 million will support him getting it across, getting it to that phase where he's confident that he'll be able to prove his research. So that's what we're playing off of, and we're trying to keep it simple, Brian. Really, our campaign goal is if 1 million people donated $22, that gets us to that 22 million. We're not about begging corporations that. It's just really it's a grassroots campaign. We know it's tough times. We're not asking people to dig too far into their pocket. And the way we're looking at it, using social media and any kind of networking event, we'll hit that target. And that's really our goal, is to keep it simple, humble, but direct. Almost all of it, as much as we can. We have to write tax receipts, and Canada Helps is the organization that we go through. But let's get that money right to Dr. Shapiro and let him buy the bioreactors, the reagents, hire the people he needs, grow this thing, so we can get it. And the vested interest in myself is my son, my sister-in-law, my cousin's children, now their grandchildren, plus the millions and millions of diabetics around the world.
Just out of interest, Mark, do you know, are there 1 million people with diabetes in Canada?
Oh, yeah. Well, Dr. Shapiro, what's the, I'm trying to, there's definitely over 1 million people with diabetes in Canada, well over 1 million, probably.
Sure. I mean, at least one in 10 people have some form of diabetes, and many of them have it and don't know it. There are around 300,000 patients with type 1 diabetes in Canada, and there's a lot more type 2s.
So if you get those people, 1 in 10, so that 3 million people, to give you your $22.
Right? Yeah, that's exactly. But the bigger thing. So with this our campaign team of generous volunteers, none of which, other than one, has any ties to diabetes. They're also seeing a business case. $12 billion will be spent this year on diabetes-related treatment. And that's going to grow to 20 billion worldwide, over $1 trillion. So imagine what we could do with that money, Brian.
If you can solve diabetes.
Exactly.
Well, let's come to that. And either Mark or Dr. Shapiro, what is the cause of diabetes? Let's talk about type 1 first of all. And then what I understand is the incidence of type 2 diabetes is growing exponentially. Maybe you can tell me, after type 1, what's the cause of this exponential growth in type 2?
So the exact cause of type 1 diabetes is not known. We know that the immune system somehow ends up attacking the pancreas by mistake. Why that happens, it's not really fully known, and I think it's variable in different patients. So in some cases, the patient gets a mild virus, like a CMV virus or another virus, and the body makes antibodies to the virus. And as that happens, those antibodies have a side effect, if you like, and they start attacking the islet cells inside the pancreas and wipe out the beta cells that make insulin. So there are various triggers. Some, children get diabetes, babies get diabetes occasionally, adults get it, type 1. So it's an autoimmune process, and there's a genetic risk to it. So in your genes, you have a risk, and then there's a trigger.
And I had understood, I thought that most people that got type 1 diabetes got it in their teenage years. You're saying that babies and adults can also get it? They
definitely can. And we see many adults that get it much later than their teens.
Yeah, absolutely. Now, and Brian, my son Spencer was diagnosed at 2.5, and my sister-in-law was diagnosed at 19. I know people are diagnosed in their 30s, so it's all over the map.
Now, type 2 diabetes is often called adult onset diabetes. So, is type 2 diabetes is different? Can you explain how one gets type 2 diabetes?
So type 2 diabetes is a little bit different. So what happens there is the body becomes resistant to the insulin that the pancreas makes. And there's various reasons why that may be. I don't want to get too scientific with it, but maybe the receptors that the insulin latches onto become resistant to the insulin. And then the pancreas tries to make more and more insulin to overcome that. And eventually the pancreas burns out and the islets die from sort of exhaustion. And there may be various reasons in various patients. Sometimes there are genetic factors. Sometimes it's related to obesity, to lifestyle. It's complex. Some patients are very much overweight, but you do also see patients with the type 2 diabetes that are lean and slim.
And the solution right now for type 1 diabetes is insulin. What is it for type 2 diabetes?
Well, many patients can be controlled with diet, but diet alone and dietary modifications are tough and don't always work and can only sometimes be short-lived. Some patients undergo surgeries. It's called a gastric bypass, where you bypass the stomach, complex surgeries that carry potential risk, and that can sometimes reverse type 2 diabetes. Other patients have to take powerful drugs that increase the sensitivity of insulin in the body. Drugs like metformin, sitagliptin, other drugs like that can improve the lifestyle for patients with type 2 diabetes. And a large proportion of patients with type 2 diabetes also have to take insulin injections over the course of time.
Now, I've been diagnosed as pre-diabetic. What does that mean?
It means you have a propensity to develop type 2 diabetes over the course of time. So were you to become increased in weight or your other factors were at play, you could potentially develop type 2 diabetes.
In the last year during COVID-19, we've heard that a lot of people with diabetes are more susceptible to maybe not getting COVID-19, but to suffering very badly from COVID-19. Why is that?
Well, I'm certainly not an expert in COVID. We're all learning fast in that respect. But it's one of those factors that diabetes is an immunomodulator, so it alters your ability to fight infections. So when you have diabetes, you have more risk of skin infections and other kind of infections. And I think in this case, it must somehow paralyze the ability to fight the virus and maybe in some cases increase the negative responses to a virus that lead to all the complications from COVID, like the respiratory failure, etc.
I've interviewed a couple of different physicians and infection experts in regards to COVID-19, and it appears that there is a far higher incidence of COVID-19 infections, and also then in people being admitted to hospitals. So infections that are more severe, particularly within African American and some other groups that would be lower in the socioeconomic spectrum. And they don't think it's racial, and they don't think it is income related. They think it is diabetes related. So it's that for some reason, people in a lower socioeconomic segment of society end up being more susceptible to diabetes on a proportion, and then end up being more susceptible to COVID-19. Does that make sense to you at all?
It makes sense. I don't pretend to be an expert in that area, but it does make sense.
Mark, it sounds like you've got a big job ahead of you. How are you going to go about raising all this money? Do you have a website?
Well,
do you have a program?
Absolutely. It's underway. We had our launch in June, Brian. We have a website, heading, headingto2022.com. Heading to 2022.com is our website. Lots of information on there, plenty of ways to donate. We have all the social media feeds, Twitter, Facebook, Instagram. Really, that's been our big push. We've seen a lot of good results from people hearing about us through shows such as yourself and others. And the uptake has been phenomenal. People are really inspired by Dr. Shapiro work, much like we are. But yeah, our website is such an easy place to go to. It's really simple to donate. We're asking for 22, or if you can afford more, even better. But one click, it takes you to Canada Help, and away you go. And also, if people want to just donate directly, not through Canada Helps, we're there too. And it's really important. 95+% of this money is going to support Dr. Shapiro, his team, his colleagues across Canada, get this across the finish line.
Heading to 2022.
2022.
Fantastic.
Again, the 100th anniversary, heading there. When we're brainstorming the name, because it made sense to me. We're on a path. Dr. Shapiro's on a path. We're putting a shoulder to the wheel with him. We're helping him all the way. We're inspired. It makes sense. We just love it. It's such an important cause, and we're just trying to make it simple. We're trying to be transparent. People will see where their money's going. They'll see information on Dr. Shapiro's research. We're all about accountability, transparency, simplicity. That's what we're trying to be.
Excellent. Well, good luck. So maybe Dr. Shapiro can ask you a couple, random questions, if I could. So these 4 factors in the that you add to the blood to take it back in time, and then grow the blood cell, the stem cell, effectively forward to create an islet cell. Could we do this with a whole bunch of other cells, heart cells and lung cells and brain
absolutely.
cells?
That's all what personalized medicine is about. Taking patient's own cells. You could just take the same blood cell. The beginning stages are identical, whether you want to make a heart cell or a skin cell or a nerve cell. Take it back in time with the Yamanaka factors, steer them forward in time in the direction you want to take them. And so other scientists are working on making, for example, there are clinical trials right now where they're making cells for the retinal pigment epithelium so that blind people potentially could see again. There are clinical trials moving forward with heart stem cells that are, again, made from patients' own cells. The idea there, again, is that you could maybe strengthen the heart after it's been through a heart attack. Maybe you could, the areas of ischemia where there's not enough blood supply, you could put these new stem cells in there and allow them to regenerate and repair. Maybe in Parkinson's disease, where there's a shortage of a particular factor called dopamine, and you could put these nerve cells that make dopamine inside the brain, and patients' own cells again that make dopamine and potentially reverse Parkinson's disease. So there's many opportunities and many different diseases where stem cell technologies could make big advances in the future. They're definitely the wave of the future.
You said earlier that you specialize in liver transplants, I believe. Could we actually grow a liver?
Well, so growing an organ is a bit more complex. It is possible to grow organs. People have taken adult human livers and kidneys and hearts and turned them, taken all the scaffold away basically, and removed all the cells, but left the holding tissues, and then on there have added stem cells to grow new organs. So the hope is potentially that the organs could be grown that way. Whether it will happen in reality and whether those organs will be, truly effective or not, it remains to be seen. But I think it's much more complex trying to grow a whole, mechanical organ like a kidney or a liver or a heart than it is to grow a cell that makes insulin.
I can imagine. You said that I think earlier when we were talking about liver transplants, that when one gets a liver transplant, you have to take anti-rejection drugs, and that one of the causes of the anti-rejection drugs is cancer. Why would a liver transplant create rejection, need anti-rejection drugs, cause cancer?
So when you transplant a different person's tissue or organ into your body, your cells recognize those cells from the other individual as being foreign. And in order to stop the organ from being rejected and destroyed, you have to take anti-rejection drugs. They paralyze the immune system. That's what they do. So there's various drugs like tacrolimus and sirolimus and Cellcept and steroids, prednisone. These drugs and other antibodies too prevent the cells from being destroyed by your immune system. They paralyze the immune system. And that very same process of paralyzing the immune system can destroy the surveillance mechanisms that would normally pick up a cancer cell. So in your body every day, you have rogue cells. You have cells that have the capacity to turn into cancers. But you have a... Hold
it. I apologize. Every day you have rogue cells that could potentially turn into cancer?
Every single day, probably millions of cells. And your body's there sampling those cells all the time, looking out for them. And if there's any cell with any abnormality, wipe it out. That's what the immune system, your own immune system does. So as soon as you paralyze that process, you increase the risk of certain cancers. And by the same token, your body is able to fight infections. It has natural resistance. When you give anti-rejection drugs, you remove that resistance and therefore increase the risk of certain infections.
So what's interesting for me, Brian, in this, when this was announced 20 years ago, many of us that have family members or people living with diabetes celebrated it initially. And we were quickly told it's an important milestone, but in this case, the treatment is almost worse than the disease. My son Spencer, he could probably live healthier without having those anti-rejection drugs. And as promising as it was, I love the Dr. Sparrow. I like how it was a proof of concept that we can actually do this. But to your point, and I've always been inspired by this, it was just an important step in this direction. So, it's important for people to know that. It's one of our committee members, Tim Schultz, is a patient of Dr. Sparrow's, and he recently He had to have islet cells transplanted again. And he showed our entire team. He said, here's my blood sugar is really high. I just had this islet cells transplanted. And now he says, I'm off to insulin. I'm feeling good. But he's taking these anti-rejection drugs. He has to be disciplined. But for him, there was no other choice. And I think that's been the case. Correct, Dr. Shapiro?
Yeah, but Brian, I don't want to overstate the risks of those drugs. I mean, there are thousands upon thousands of patients with successful organ transplants that take these medications every day to save their life. And the risk is not that high. However, if you have type 1 diabetes and you're a child with diabetes or a young adult and you're doing fine on insulin, why take that added lifetime potential risk of developing a cancer or developing a life-threatening infection? So that's why our original treatments are not perfect for all patients with diabetes. They are certainly perfect for patients that have really difficult to control diabetes. But for everybody, if you're looking for treatment for everybody, eliminating the need for those anti-rejection drugs would be a big deal.
We're chatting tonight with Dr. James Shapiro of the University of Alberta in Edmonton and Mark Bosworth. The two of them are involved in heading to 2022, a program to raise money, $22 million to support the phase 1 research into Dr. Shapiro's discovery, really, and desire to create your own cells that can create islet cells that will solve the insulin production in your body and cure potentially diabetes. We're going to take a break and come back with some concluding comments in just a minute. Stay with us. Well, welcome back to the Brian Crombie Radio Hour, Saga 960. I think that we've learned a lot about diabetes tonight. It's a disease that 423 million people around the world have, according to Dr. Shapiro. Over 3 million people in Canada have diabetes, both type 1 diabetes, which is something that people get, I think mostly when they're teenagers, but according to Mark and Dr. Shapiro, babies can get it, adults can get it. But what I hear about more and more is a massive increase, exponential increase in type 2 diabetes, and obviously a problem that's going to grow and cause several $1 billion of impact on our healthcare system in the future. And so therefore, what Dr. James Shapiro has come up with as a sort of a successor to the Edmonton protocol that he developed about 20 years ago is a way of taking people's own blood cells, adding 4 factors to them such that they become effectively the cells comparable to what they were when you were just conceived, and then grow them over 28 days, mature them into islet cells that are the cells that create insulin, re-infuse them into the body, into the liver, and potentially cure cancer. Cure diabetes. And what Mark Bosworth is interested in doing is raising $22 million to try to help Dr. Shapiro with this first-in-man clinical trial to prove his concept. Mark, tell us what you want to do.
Dr. Shapiro needs to stay laser focused. He doesn't need the noise of worrying about will they have enough funding. And that's really what we're doing. Our little mantra tagline, let's cure it, be one of a million people. And that's what we're doing. And Brian, I know you have a lot of followers, a lot of viewers, listeners, and many people on their various social media channels have people that they're connected to. And if we can just tap into that network and we can ask people to donate $22 or more if they have it, we believe 1 million people can donate to this, and we can give Dr. Shapiro the money he needs to be laser focused and get this done and get it across the finish line. Diabetes is a relentless disease. I've watched my son Spencer, who's now 28, live with it for 26 years. He doesn't want anyone to feel sorry for him. He tries to keep it low key, but I've observed it. And if this is what it's going to take, I'm behind it. I hope Canadians join us and really dig in on this, yourself included, Brian. Let's just get behind this. So
if 1 in 10 people in Canada have diabetes, that's got to reach almost every family.
I would really think so. People, it's, the 6 degrees of separation, look around. But the problem with diabetes is people aren't flaunting. It's not necessarily visible, but it's there, believe me. And it's an expensive disease. Insulin pumps that Spencer wears, $7,000. He's had 3 of them. Start to do the math. And that's the cheap part. It's the infusions, it's the testers. And those are beautiful mechanisms to allow him to live a sort of normal life. But I mean, how can you not be inspired by the work of Dr. Shapiro and his team and his colleagues? And that's why we're all getting behind us. It's
Mark, remind us of the website.
Heading to 2022.com, HEADINGTO 2022.com. Tons of information, easy ways to donate. And then, follow us on Facebook, Twitter, Instagram, super easy to find.
Dr. Shapiro, this has been really quite a informative and frankly inspiring conversation for me. Thank you so much. What's your final comment? Do you think you can actually achieve this?
This is absolutely doable. You make these cells from humans, you can do it in a mouse, you can do it in a patient. Connecting the dots now and getting to the next stage there's going to be challenges, but it's definitely doable. We just have to get there. As Mark said, we have to stay laser focused on our task and look at our immediate challenges ahead. But this is a solvable disease. Cells will do it. Cells are the way of the future, and stem cell, this kind of approach, patients' own cells, I believe, is absolutely the way to get there.
Dr. James Shapiro of the University of Alberta in Edmonton, and Mark Bosworth, head of co-chair of this committee, heading to 2022.com. Thank you so much for joining us and educating us on diabetes, the growth of diabetes, the Edmonton Protocol, and this new potential cure for diabetes that sounds pretty spectacular and pretty out there. Stem cells that we effectively come from ourselves. Kind of exciting. Well, that's the Brian Crombie Show for tonight. Thank you so much for joining us. Really appreciate it. Good night, everybody.